The inspiration is always with us, and they are Dr. A.F.M. Kamaluddin. Dr. Kamaluddin is Scientific Secretary in Oncology Club. We are very happy today that our General Secretary, Professor Dr. M.M. Shariful Alam sir, is with us. Welcome, sir, to this. For a long time, you are with us in this session.
Thank you. Thank you. Welcome.
Thank you, sir. And our inspirator, always inspirator, Professor Dr. E.M.A. Hi, sir. Sir is the president of Oncology Club. Sir is sick today, so he is unable to join this program. And supporting the fighters, the admiring the survivors, honoring the taken, and never ever giving up hope. Thank you all. Now I request the Mr. Mehdi Hassan to show the poll questions before starting the tumor board cases. We first show the poll questions to you all, and after the end of the poll questions, all the participants are requested for poll voting. And at the beginning, we shall show you the poll questions. At the end, we'll show again the questions, and we will see how many percentage they give the correct answers. And at the next week, we will announce the winner of 3 among all the participants. The 30 seconds only. For each questions, maybe it's only 30 seconds. Okay, maybe please stop the screen, the poll questions from the screen.
I stop it.
Okay. Thank you, Mr. Mehdi. Now I will request our Secretary General of the Oncology Club, Professor Dr. E.M. Shariful Alam sir, to give a comment for this sessions, the Oncology Club, the tumor board sessions, and give us permission for starting the original session. Sir, please.
Thank you, Professor Shahana. Can you hear me?
Yes, sir.
Okay. I welcome all of you to this tumor board session on vulval cancer. Gynecological oncology department of oncology club, which is holding and doing everything by Professor Shahana, is regularly arranging such a gynecological oncological program on behalf of Oncology Club. She is very much interested and enthusiastic in arranging this session, and that's why Oncology Club is very much grateful for her activities, and we are appreciating her activities. I welcome all of you that is the respected foreign faculties and local faculties, and the participants from home and abroad who are participating this tumor board session on vulval cancer. Now, I will request to start the session, and I hope this session will be very much interesting for all the participants. And I hope to be with you to hear the presentation and discussion. Thank you all.
Thank you very much. Now today our first presenter is Dr. Sabrina Kader. Dr. Sabrina, please present your case. Sabrina, she has complete the fellowship in gynecological oncology this year from National Institute of Cancer Research and Hospital. Sabrina, please, over to you.
Assalamu alaikum, madam. And assalamu alaikum, everyone. I'm Dr. Sabrina Kadir from NICRH. Going to present my case. Mrs. X, 68 years, who para 4 living 4, having hypertensive and diabetic lady, who attended outpatient department of NICRH with complaints of vulvar itching and pain for 2 to 3 years. On examination, her BMI was average, she was mildly anemic, and blood pressure was 120 by 80 millimeter of mercury, and accessible lymph nodes are not palpable. On locoregional examination, a 4 into 4 centimeter ulcerated lesion was present in vulva, involving whole of the labia minora and inner aspect of both labia majora, extending from urethra and clitoris and up to posterior forkity, and not fixed with underlying structure. This is the view of the lesion of that lady. So my first question is, how will we evaluate this lady? How to confirm the diagnosis, and what investigation are needed for detection of extension of the disease?
Okay, shall I answer the question?
Yes, sir, sure.
Okay. This lady has an obvious growth on the vulva, and it is more than 4 centimeter.
Yes, sir.
Involving the clitoris and also involving the lower urethra.
Yes, sir.
So we'll have to confirm the biopsy, confirm the diagnosis by a punch biopsy.
Yes, sir.
So you have to take a good biopsy to include the underlying stroma to know the depth of the invasion. But clinically, it looks like invasive vulval cancer. So you need to confirm the diagnosis by a good punch biopsy.
And sir, for extension of the disease, what imaging is the best?
Yeah, most important thing is that you'll have to examine the bilateral groin.
Yes, sir.
Okay, and apart from this, you'll have to ask for a contrast enhanced CT scan or contrast enhanced MRI scan of the groin, pelvis, and abdomen to know the spread to the inguinal regions, and also to exclude the involvement of pelvic lymph nodes. It is better to do a contrast enhanced CT scan or contrast enhanced MRI scan.
Sir, which option will you prefer among these two, either CT or MRI?
No, I think both are equally good. I think as far as the lymph node status is concerned, I think both are equally good. Depending on the experience, your experience, you can choose either CT scan or you can choose MRI scan. I think there's nothing much, I think, to choose between these two modalities.
But for local extension, the MRI is better for local extension. Is it not superior?
Yeah, local
MRI?
extension, I think MRI scan would be better. I think more than MRI scan, I think probably local extension you have to judge clinically. Clinical palpation is more reliable than either CT scan or MRI scan, because if you do rely only on imaging, then the findings may be misleading. Here, when you examine the patient clinically, you have to look for the mobility, whether the lesion is moving, whether the lesion is confined to the skin, whether it is free from the underlying bone. So all these things, I think we can make out very clearly with clinical examination. I don't think MRI scan or CT scan would matter much here. I think most important thing would be the clinical examination.
But sometimes we have seen that some centers, they do the both CT and MRI. In some cases, also primary
Because
and
I
also
think
in
probably I think if you are think clinically, if you are suspecting involvement of the urethra and suburethral region, then probably you can ask for MRI scan on a case-to-case basis, because MRI scan is good for knowing the soft tissue invasion. It is more reliable than CT scan. So if you feel that the urethra and suburethra is involved, then better to go for MRI scan. But clinically, if you feel that the lesion is mobile, the skin is moving freely, then I think CT scan is good enough. Or you can ask for MRI scan also. There's whatever facility you have at your center, you can choose either CT scan or MRI scan. But for soft tissue invasion, I think probably MRI scan is good.
Sir, whether cystoscopy is needed for urethral involvement?
Cystoscopy is not needed. Generally, I don't think I ever done cystoscopy unless you have the involvement of the upper urethra. Upper urethra is involved, then probably you have to go for a cystoscopy. On a routine basis, cystoscopy is not indicated. I never done it in my last 3 decades of practice. If it is, if you are sure that lower urethra is involved, upper urethra feels normal, and there is no obstruction to the urine flow, then I don't think cystoscopy is going to add to anything, because we have such a good imaging in CT scan or MRI scan. So I don't think you have to do it routinely, unless the upper urethra is involved and the upper vagina is involved.
AK? AK?
Hi there. Sorry, I'm in a noisy place. Yeah, I actually agree, and I very much agree with the idea of doing an MRI to evaluate the extent of disease. It looks very significant.
Yeah. In your center, if you get this type of cases, then you will advise for MRI.
Yeah, I would do an MRI. We would also do a PET CT scan as well to look for distant spread. But in terms of understanding the local extent, the MRI is your best test.
But do you advise both PET CT and MRI both?
Yeah.
Why? But I think we have seen that is a locally localized disease. There is also no clinically no inguinal lymphadenopathy. Even after that, you will advise PET CT.
Yeah, in a resource-rich environment, you would do that because with something, your nodal involvement is completely dependent on size.
Yeah.
So even if clinically you think that you're fine, just based on the size of that lesion, you have I'm going to guess, over 20% risk of nodal spread, maybe even higher, just based on size.
Yes, sir.
In our setup, perhaps the MRI one imaging is sufficient, And with this disease, if there is no palpable or suspicious inguinal node, I don't think there is a spread to other than the inguinal area. So perhaps in this particular case, I should go for this MRI as I second Dr. Bafna, that MRI will give really information how far it has gone in. Mostly it has gone towards little bit more towards vagina and urethra. That is the only thing, whether it is involved the upper urethra or not, that needs to be known by MRI can give some diagnosis on that issue.
Okay.
And PET CT usually there is no need. PET CT is only indicated when there is an advanced disease and only recurrent settings mostly.
Yeah, I agree with Dr. Giri. I think a PET CT scan sometimes it may give you false positive reports, especially when we have taken a vulvar biopsy, or if the vulvar lesion is necrotic and there is an infection in the vulva, and you do PET CT scan, then you may find false positive pelvic nodes and inguinal nodes. So we don't routinely advocate PET CT scan. We are happy with either MRI scan or CT scan. We don't generally advocate PET CT scan,
Okay.
PET scan.
Yeah. Okay. Sabrina, proceed.
Sir, whether colposcopy is necessary here to evaluate cervix, if perispicular examination and bimanual examination reveals normal findings?
Yeah, normally what happens is that these kind of lesions may be associated with HPV infection. Okay, vulvar cancer is of two types. Either it is because of HPV or it is because of non-HPV caused because of lichen sclerosis and vulval dystrophies. They are not usually associated with HPV infection. So it's better to do a colposcopic examination, or first before doing colposcopy, better to do a pap smear test from the cervix to rule out any multifocal lesions arising from the vulva as well as from the cervix. So better to do a pap smear. Then if required, you can do colposcopy also, if pap smear is showing some kind of abnormality.
Colposcopy can add to the extension, area of extension, how far it has gone in. By doing this local side, this is you can know the external disease, how far it has gone in. The you can just map the lesion where it has gone. So it can give how deeply it has gone into the vaginal area, because it has gone in. That we can know the demarcating line can be known from that.
Yeah. Sometimes I think this particular case colposcopy may not be possible. I think.
Yeah, that's true.
Because it looks very stenosed to me from here. Looks very scarred and very stenosed. So I think colposcopy may not be possible in this particular case. Technically, it will be difficult.
Next.
Thank you, sir. So this is an article which was published in 2019 saying state of the art in vulval cancer imaging, and it says that MRI is useful for finding nodal and local staging as well as facilitating the planning of surgical intervention and radiotherapy. CT or PET can also play an important role in nodal and distant disease assessment, whereas ultrasonograph is often used for image guided biopsies, as already has been mentioned. So what we did to confirm the diagnosis, we did punch biopsy from the lesion. It revealed squamous cell carcinoma vulva grade 1. And for extent of the disease, we did CT scan whole abdomen, as it is cheap and available in our hospital. So this is the CT scan view of that lady of whole abdomen, and it shows no inguinofemoral lymphadenopathy. So my next question is how to treat this lady.
I think this particular clinically, if you think that the disease is confined to the lower urethra, and if the vulval skin is mobile, that means it is not fixed to the underlying bone. Then I would like to offer her, and this is involving lateral as well as central vulva.
Yes,
That
sir.
means the labia minor also is involved, urethra also is involved. And this is a bilateral disease
Yes, sir.
involving both right side and left side. So there is no role of sentinel node biopsy here because it is bilateral, it is involving the central vulva. So absolutely no role for sentinel node biopsy. So what I would do is I would like to do a radical vulvectomy. Okay, and along with that, at the same setting, I would do bilateral inguinofemoral node dissection by separate incisions in the groin.
Sabrina, next.
So what is said in NCCN guideline? It says as it is early stage and it is T2 lesion, so vulval central lesion, which is anterior or posterior, it says that radical partial vulvectomy and bilateral inguinofemoral lymph node dissection is the standard of choice. We all know that.
I like to refer here. This lesion is more than 4 centimeter.
Correct.
The lesion is more than 4 centimeter. It is only the lesion. This is a T2 lesion,
Yes.
which is smaller T2 lesion. Is less than 4 centimeter. There it plays the upper part plays. But when it is a T2 lesions more than 4 centimeters, radical partial vulvectomy will not. There is because whole of the vulva is involved.
Yes.
There is no
Modified
question of partial
radical
vulvectomy is not there. So radical vulvectomy is the
Yes.
need for this patient, along with no sentinel node, because it is more than 4 centimeter. There is no need of going for sentinel biopsy. Here is the role of bilateral inguinal lymphadenectomy.
Yes, sir. Next.
Yes, sir. And the single most important factor to decrease mortality and morbidity in early vulvar cancer, we know that lymph node dissection is the most important. And in this lady, as she has bilateral lesion and it is more than 4 centimeter lesion, so bilateral groin lymph node dissection is the standard of choice. So what we did, this lady underwent modified radical vulvectomy and bilateral inguinofemoral lymphadenectomy on 19th November 2021. This is the 14th post-operative view of that lady.
Terminology here, modified radical vulvectomy is somehow little bit. I have got some reservations because modified radical vulvectomy means either partial vulva to be removed. When not the whole vulva is removed, it is called modified radical. Okay, when whole vulva is in here, whole of the vulva has to be removed.
Radical vulvectomy.
So most probably you can say radical vulvectomy was done.
Yes,
Yeah.
sir. Yes,
Yeah.
sir.
I would agree with Dr. Giri. You cannot call it as a modified radical vulvectomy. You have to call it radical vulvectomy because whole of vulva is involved.
Yes, sir.
Okay, sir. This and this is the 14th post-operative day of that lady. And the histopathology report. Histopathology report says it is invasive squamous cell carcinoma grade 2, and it also says that it is 4 into 2 centimeter lesion and deep resection margin was 0.5 centimeter away. And macroscopically, we see that lymphovascular space invasion is present, but peripheral resection margin and deep resection margin both are free of tumor. So my next question is whether she needs adjuvant treatment.
Dr. Bhavana, please. Dr. Bhavana, madam, please.
Yeah. Hello. Good
Yeah.
evening. So,
evening.
okay, so if I couldn't read the pathology report, but what I got to know was the tumor size is more than 4 centimeters.
Yeah.
VI is positive,
Yeah.
and the resection margin is
Negative.
0.5 0.5.
Yeah.
Yeah, but it
Yeah.
is 0.5.
Yes.
0.5 centimeters.
Yeah.
Yes, ma'am.
Yeah, so she has an indication for post-op radiation to the tumor bed. Now, I wanted to know the status of the lymph nodes.
Yeah.
All lymph nodes
How many removed and all negative?
All
yes, all are
yeah.
negative.
How many removed?
Right side 6 inguinal and left 5 inguinal lymph nodes.
So the indication for treatment is basically to the local area, that is the local vulvar region, because there is a risk of local recurrence because of these points, that is tumor size more than 4 centimeters and LVI positive.
Yeah.
And the margin is, it should be 1 centimeter of formalin fixed margin of 8 millimeter. So since it's 0.5, we'll give her only local radiation to the vulva and she does not need radiation to the inguinofemoral region.
But she has LVS, she had LVSI positive.
Yes, so she will require radiation to the vulvar region.
Yeah.
Yeah,
And-
but lymph nodes are negative. So we
Yeah.
don't need to irradiate the groin.
So my question to you, Bhavna,
Yes,
so
Dr.
are you happy with the number of nodes dissected on inguinal?
Yes.
Yes, Dr. Kamal, actually there is no consensus, but in one of the
consensus, yeah.
FIVO guidelines, they said that, 5 or more
Yeah.
could be considered as adequate.
Yes.
So
But
Shahna was trying to bring up the issue of LVI.
Yeah.
So are you going to add concurrent or only radiotherapy?
No, only radiotherapy. Concurrent is node positive disease, and that is where the concurrent has benefit in terms of survival also. So it's either the node positive disease or when we are treating a advanced cancer upfront with chemoradiation.
So the question she was bringing up intentionally was, I think, the
Yes.
LVI. So can you
Yes.
please shed some light on the role of LVI in vulva? Because LVI have a big role in endometrium. Also,
Yes.
we consider in cervix. But here, what is the issue of LVI here?
Previously,
Do
yeah.
not consider LVI as an independent prognostic factor. For
Yeah.
one thing we have to realize for survival, it's the lymph nodes that determine the survival in vulvar cancer. For local recurrence, it is the local disease or that determines the local recurrence. So here she has a chance of local recurrence. So the LVI is basically going to result in increased local recurrence. I agree that if LVI is positive, there is also a chance of local as well as recurrence to the lymph nodes. In this particular case, the lymph nodes are negative.
Okay. Yeah.
Because we will be increasing the morbidity by irradiating the inguinofemoral region.
That is quite critical, Bhavna, that for us, treating inguinal node is a havoc. So we try to avoid when there is a possibility.
Yes,
That is,
yes,
even after surgery, that is more dangerous.
yes, and age also, she is 70 years of age, isn't it?
No,
She's 68 years.
68. Yeah.
Yes,
Around
70.
70. Around 70. Yeah.
60, written 60 here.
Yes, there is no indication of chemotherapy, concurrent chemotherapy in this patient.
Yes. So that is the issue that Bhavna want to give the message that inguinal, when after surgery, we don't want to radiate because of the lymphedema. We are not giving benefit, but we are inviting the, serious complication of lymphedema.
Dr. Bhavna, why you give the emphasis on the depth of invasion? Depth of invasion.
Yeah, depth of invasion basically
Yeah.
determines its an indication for lymphadenectomy also.
Yeah.
So these are when we look at the HEAPS criteria. So
Yeah.
these are the criteria that we take into account which confer an increased risk of local recurrence. So one of the factors that we take into consider is the depth of invasion, more than 5 mm.
But sometimes we have seen in our histopathology report that it was written that the LVSI positive, sometimes it is written that the perineural invasion positive. And what is the importance of this perineural invasion?
Basically, any invasion, whether LVI or perineural invasion, see, independently, they are not acting as independent prognostic factors. Yes, they are being considered as prognostic factors for local recurrence. So if there is something like this, we do consider these patients for local radiation. We do consider this as a factor for giving local radiation.
So perineural,
Not like cervix where we will consider, to intermediate risk. If any of these factors are present, we consider these patients for local radiation because a local recurrence in the vulva is
Yes.
very bad.
Yeah.
The only condition we ask, suppose the patient has a closed margin, that is the time, if that is the only factor, that is one condition where we can ask for revision of margin if it is
Margin,
possible.
yeah. Yeah.
Otherwise, we go in for adjuvant radiation.
So what message Dr. Bhavna Madam, she has given to all of us? We must have to clear about the margin of the resection margin. If the resection margin is positive, there is in vulvar cancer, we can go for the re-resection. As because there is no LVSI, no perineural invasion, no lymph node involvement, and if it is resection margin is positive, in that cases we can go for the re-surgery because to show the margin negative. If that margin is again negative and there is no lymph node involvement and there is LVSI negative and no perineural invasion, we can only go for the follow-up, that is observation of this patient. So in histopathological report, it is very important to mention this perineural invasion and also the LVSI along with the lymph node status.
And one should always ask for these complete details from the pathologist.
Yeah.
So that is another message.
I think one more thing I would like to add here is that when you talk about surgical margins, we
Yes.
have lateral surgical margins.
Yes, sir.
Lateral surgical margins is quite easy to obtain.
Yes.
But to have deeper margins, especially around the urethra,
Yes, sir.
suppose the vagina is involved posteriorly,
Yes, sir.
we are very close to the rectum.
Yes.
Anteriorly, if the urethra is involved, we are very close to the urethra. So getting a deep margins around urethra and around the rectum is very, very difficult.
I completely
Laterally, you
agree
may
with
get a
you.
margin of 1 centimeter, but depth, certain areas is very, very difficult to obtain, practically speaking.
I
Very, very
completely
difficult to
agree with you, sir. In fact, most of the midline tumors which are involving the clitoris do require post-op radiation because of this reason.
No, also for anorectal invasion, in that cases, in 4 centimeter, in that cases, even the
Yes.
deep margin negative, we shall
Yes.
also go for the
Yeah, so once
irradiation.
it's involving the midline structures, invariably the radiation indication
Yes.
is there because it is very difficult to obtain a deep resection margin of more than 1 centimeter.
Okay,
So
sir.
most of the patients do land up having an indication for post-op radiation.
Yes, but I have a question to you that is sometimes we see that in advanced imaging, if there is a lymph node the positive, the lymph node the lymphadenopathy, in that cases, can we go for the FNAC to exclude whether she had, as we know, if the FNAC positive, the patient, she needs the adjuvant radiation. In that cases, should we remove that lymph node?
Are you
If it is
talking about the
positive?
pelvic lymph node or inguinal?
Inguinal lymph node.
No, sorry. Can you
Is there any role of FNA or core biopsy if lymph adenopathy, as because we know if it is the positive, in that cases, we shall go for the irradiation in that area. Is there any role of lymphadenectomy in that case?
you mean if it's a locally advanced disease and lymph node is enlarged?
Yes.
Yes, there is role of lymphadenectomy even in locally advanced diseases. If a lymph node is resectable,
Yeah.
the patient should undergo lymphadenectomy, inguinal lymphadenectomy, even in advanced diseases.
Why?
Because radiation alone is usually not sufficient to control grossly involved lymph nodes, especially if the lymph nodes are enlarged.
Yes.
So radiation is not usually, I mean,
so why I have taken this issue as because we know in case of cervical carcinoma, if there is a lymph node is positive, then we postpone the surgery and we will go for the irradiation and chemoradiation. But in vulvar carcinoma, there is even if it is the positive or enlarged lymph node that is locally advanced disease, in that cases we must go for the lymphadenectomy, because what Dr. Bhavna madam, she told that the only local radiation cannot clear this area.
I'd like to differ here, sir, madam. The whole problem, when the lymph node is clinically or radiologically suspicious,
Sir.
we'll try to remove the lymph nodes, send for frozen section. If it is positive,
Sir.
Try to remove the enlarged lymph nodes. Do not proceed for systematic lymphadenectomy. There is no need of, because anyhow you have to go for radiotherapy. So only remove that node and send for frozen sections. If it is positive, if it is metastatic, try to remove the other nodes which are enlarged and stop going for further lymphadenectomy. There is no need of going for it, because it will add more morbidity.
Yes, sir. Bhavna madam, she told that in favor of that, the enlarged lymph node, the radiation cannot clear that area.
That's why you should remove that.
Yes, sir. So that is what even, I think we are basically on the same page, that we mean that any enlarged lymph nodes have to be removed, because radiation alone cannot take care of enlarged lymph nodes.
Eke, what is your opinion? Eke? Okay.
Yeah, great discussion. So I actually have several thoughts. Just to go back to the issue of the primary tumor and the margins, I completely agree with the discussion about the, we have data that suggests that we need a good 8 millimeters in fixed tissues to say that we have a good enough margin. The other option you do have, aside of radiation in the absence of positive lymph nodes, is to go back and re-excise. So that's just another option depending on your resources and the particular location of the close margin that you have. For instance, I think to the other point of, is it a lateral margin? Is it a medial margin? Is it on the urethra? Where exactly is this margin? You could consider going back and just re-excising. So it's just something else to think about as you decide what to do with your patient. The other point, just to bring up, with such a large tumor and with lymphovascular space invasion, and I think Dr. Shahana, you're bringing up this concern, is it possible that you missed the positive lymph node on your lymph node dissection, right? So, you know, are you really, really sure you comprehensively did a good lymphadenectomy? I'm sure you did, but just to think about it, one of the interesting things about sentinel node vulvar dissections is it's taught us that actually the sentinel nodes are more likely to be very, very medial. And I'm impressed with the fact that I worry in a classic traditional lymphadenectomy, inguinal lymphadenectomy, that I'm not going medial enough with my margin. Okay, so just to think about that. And you know the dissection you did, and I've seen you all operate. You're amazing, and I'm sure you did a very, very radical job. But that would be my one concern: is it medial enough to really reach those sentinel nodes, those first lymph nodes? Yeah, I totally agree with the point about you're happy about the lymph nodes. You're sure they're negative. You're really dealing with a margin. You've decided you're going to manage it with radiation, to do vulvar radiation. The issue of doing chemo radiation, I think, is very radiation oncologist dependent. I've seen in Boston the sort of argument that you want to add the chemotherapy so that you can reduce your fields, that you strengthen things. I don't know that I have an opinion about that. I sort of defer to my radiation oncologists. And then the final point, Shahana, unrelated to this case, is if you had a large positive inguinal node, I would absolutely resect it and then give radiation. For me, the question is, do you resect both sides, or do you just resect the positive side and then radiate the negative side? So yeah, all very, very good discussion. Thank you so much.
Okay, thank you, Sabrina. It is already discussed, yeah.
So what NCCN guidelines say? So if negative margin, either we can observe or we can provide adjuvant external beam radiotherapy, depending on risk factors. So as she has risk factor, close tumor margin and LVSA positive, so according to our tumor board decision, she was advised for adjuvant external beam radiotherapy. Thank you all for patience hearing.
Great job, Sabrina. Now our next presenter, Dr. Sushmita Sarkar. She is a resident in Gynae Oncology in National Institute of Cancer Research and Hospital. Sushmita, please.
Can you hear me, ma'am?
Yes.
Good evening to all. I am Dr. Sushmita. I am going to present my case. She is a 60 years lady, was diagnosed as a case of vulvar carcinoma from March 2016.
Share your slide.
Sorry?
Yeah.
Slide, sir. Not, sir. Slide
Please share
sharing.
your slide. Your
Sorry?
slides are not seen. Share your slides. You didn't share your slide, Sushmita.
Okay.
All are requested to put their questions in the chat box so our learned faculty, they can answer your questions. All are requested. Please put your questions on the chat box.
Can you see my slides?
Yes. Proceed.
Okay. She's a 65 years lady. She underwent vaginal hysterectomy on July 2018 due to uterovaginal prolapse with decubitus ulcer. There was a small ulcer in the vulva at the time of surgery, which was overlooked. On the specimen of hysterectomy specimen, there was no malignancy in the cervix. 1 month after her surgery, she came with a discharge from the vulvar lesion, which has increased in size. Biopsy was taken. Biopsy report revealed HCL. She was then referred to a tertiary hospital. On local examination, ulceration was seen over the vulva, including both sides of labia majora and minora, with mons pubis involvement and involvement up to 1.5 centimeter above the urethral meatus. Repeat biopsy with adequate tissue was taken and it came as invasive squamous cell carcinoma. CT scan of pelvis and abdomen revealed hypotenuse lesion about 3.2 into 4.8 into 6 centimeter in the vulvar area, but no lymphadenopathy. Wide local excision was done on 17 September 2018. Histopathology report revealed vulvar tissue about 5.5 into 4.5 into 6 centimeter with a tumor diameter of 4 centimeter in the greatest dimension. Surgical margin was free for tumor. It was squamous cell carcinoma grade 1. So whether adjuvant therapy was needed.
Giri sir, please.
We don't have any idea about LVSA or not. In the surgery session, have you gone through LVSA? This tumor size is quite more than 4 centimeter.
Yeah.
What about LVSA there or not? What is the depth aneurysm there? What was there? Because the margin is somehow it is margin 1.5 centimeter margin is there.
Yeah.
But we don't know about. But as the tumor size is more than 4 centimeter, perhaps Dr. Bhavna will agree with me. We need to go for a okay. What about inguinal node?
Yeah, all the notes are negative also.
Negative, yes, then so
Yeah.
So Dr. Bhavna will agree with me to go for a local radiotherapy to the vulva.
Yes, sir. Yes, sir. I completely agree with you, Giri, sir.
Yeah. What is in favor of your point for giving the radiation for our participant, please?
Because more than 4 centimeter.
Yeah.
MR
Yeah.
is more than 4 centimeter.
Yeah.
And LVSA you do not know. You should have gone for LVSA. LVSA status has to be sort
They
of here.
didn't, yeah.
Yeah.
Histopathology report, they didn't comment on the LBSA. Yeah.
LVSA. So and we'll be looking into to be in a better side. We should think of going for adjuvant radiotherapy.
Shana, this is what I was wanting to highlight, that it is very important to ask for complete pathological details.
Yeah.
Yeah. Yes. Next, Sushmita.
She then traveled to neighbor country for further management. At the time, there was a small cystic lesion in the vulvar region. MRI of the pelvis done and it revealed thickening and irregularity of the anterior vaginal wall with thickening of the vaginal vault. There was bilateral tiny inguinal lymph nodes. Her slide was reviewed and it said vulvar intraepithelial neoplasia, no definite evidence of invasive carcinoma, And skin resection margin and deep resection margin was free of invasive or in situ carcinoma. All resection margins from previous wide local excision were free of cysts and no invasive cancer found. Vulvar punch biopsy was negative for malignancy. She was then remained on follow-up only. So on her follow-up in 2019, she was asymptomatic and no new lesion in the vulva. She was then suggested for 6-monthly follow-up, but she was lost to follow-up. In June 2021, she presented with vulvar swelling. On examination, a hard fixed mass about 5 into 6 centimeter in the right labia, clitoris, mons pubis, along with ulceration on the upper part of the vaginal wall, and there was enlarged lymph nodes in both inguinal region. Biopsy was taken and it was squamous cell carcinoma grade 2. So regarding NCCN recent guidelines, if there is recurrence confined to vulva and clinically negative nodes, not previously irradiated, option is partial or total radical vulvectomy with or without unilateral or bilateral inguinofemoral lymphadenectomy. Adjuvant treatment is individualized according to margin status and lymph node status. Or patient can be given EBRT with or without brachytherapy, with or without concurrent chemotherapy. If the recurrence confined to vulva with negative nodes, but previously irradiated patient, partial optical vulvectomy is recommended.
Sushmita, please. But before that, this patient, she has undergone the vulvectomy and also the lymphadenectomy. Her margin was negative, but size was 4 centimeter, and even no comment on the histopathology report, the LVSI and the perineural invasion, and she was referred to radiation oncologist, but patient didn't attend the radiation oncologist. She traveled to neighboring country, and there they did the CT and MRI, and all were negative, and all the resection margins were from the slide and blocks, all were taken from here and all were reviewed. They also, in review report the same, there was margin was negative and deep margin was also, everything was negative. And they, even after that, they had advised for a follow-up for these patients. So what is your opinion in this regard?
So we have missed the trend.
Missed the trend.
Yeah. First, we should have given this adjuvant radiotherapy to the vulva. Now, and as we know that it is a HPV triggered disease, and the HPV is now is there always. And after that, she developed that is VIN3, something like that. No, then we did the again local excision was done. And we have not thought about the other areas which is, we have not gone for this vulvoscopy. The other area where the lesion is there or not. Only the lesion which is there, we will remove that. So most probably little bit, there is something which are lacking in. That's why she came in this advanced stage. And this advanced stage, the disease at the mons pubis now. No, just go back.
Go, yeah.
Hard fixed mass. Next. No, next. Present now. How she's been living now? What is the present status?
Present status is there. June, sir. Yeah, show the.
No, now she's come with. Now she's come with some large lesion. No.
ওইটা দেখান না, সুস্মিতা.
This is large lesion over here.
Yeah, 5 into 6 centimeter in right labia, clitoris, mons
pubis, all the large lesion is there.
And so, bilateral, both inguinal lymph, bilateral inguinal.
Here surgery does not have to play. Something has to be done before surgery. Dr. Bhavna will say concurrent, if it is neoadjuvant concurrent chemoradiations or only radiation can sort of. Then you should have gone for surgery. What is Dr. Bhavna's opinion?
Yes, sir. I mean, I just want to confirm one thing. She has ulceration on upper part of the vaginal wall, means the disease is involving throughout the entire vagina.
Yeah.
No. There is the growth in the upper part of the mons, the large growth that is 5
No,
into 6 centimeters.
Along with
There-
ulceration on upper part of the vaginal wall. Is this a separate growth or this is an
No.
extension of the disease
Oh,
process?
Continuous.
Disease. It is this disease
This is
area.
stage 3 disease, which is going up
Yeah.
now.
Yeah.
3, and now it's 4 of yeah,
Yes.
because of the fixity. Okay.
Yeah,
So
I would like to add 2 points here. Initially, I think you presented the tumor was extending into the upper vagina. First time when she came to you, and still you are able to obtain clear margins. I think you can go back to the first few slides. You mentioned
one of the CT said thickening of vaginal wall.
no initial slides. I think first slides upper vagina. I think upper vagina is involved.
First side.
2018.
No, first time when you did the surgery,
Before that.
upper vagina was involved, but you were able to achieve clear margins in spite of.
Not upper vagina.
No,
It is not upper vagina.
Go back the other side. Go back.
Go back. Slowly, go back. Go back. One second. Wait a minute. Bring both labia majora, minora, mons pubis involvement.
Urethra. No, you're not involved urethra. Yes.
No.
Upper, up to 1.5 centimeter above the urethral meatus.
Above.
1.5 centimeter above the urethral meatus.
Yeah.
Then vagina is involved.
Lower vagina, not upper vagina.
So upper 1.5 centimeter of urethral meatus was involved. And secondly, I think you mentioned the term wide local excision. Just go back to the next slide.
Radical valvectomy.
Modified
You have to use the word
Yeah,
radical.
radical valvectomy.
You mentioned wide local excision.
Yes.
It's not wide local excision. You have to do a radical local
Radical
excision.
valvectomy. Yes, sir.
Yeah. So you have to go deep up to the fascia. If you don't
Yeah.
go deep, then definitely patient will come back with recurrence.
Yeah.
And sometimes pathologist may give you free margins.
Yeah.
Okay. So pathological examination is very, very important. Sometimes you know that you are not given good margins. Still, you find that pathologist will tell you that margins are free because the specimen is very, very large.
It is
And
4
unless,
centimeters.
very, very difficult to give the report on vulvar specimen.
Yes.
That's why I think this patient is recurred, I think.
Yeah.
And not only that, sir, there is indications of the adjuvant treatment at the first time. There is the indicated adjuvant treatment.
Yes,
This-
definitely. There was a lot of missing information even during first time, which we should have sought for.
Yeah.
So at present, I don't think you can go for any surgery. We
No,
can't
sir.
think of any
She needs
incident.
upfront.
Upfront.
Yes.
Yes. Concurrent chemoradiations, then
Yes.
think of.
Yes, so we can either go in for a radical chemoradiation or we can go in for upfront chemoradiation as assessment for surgery. We have both the options.
Proceed.
So her CT scan of lower abdomen on June of this year revealed recurrence of carcinoma 6.4 into 2.9 into 6.8 centimeter at the left side of the vulva involving left labia majora and invasion of the urethral orifice. Bilateral inguinal lymphadenopathy was there. Ground glass nodules at around 11 into 9 millimeter at the superior segment of the right lower lobe. What will be her treatment plan?
One
You
thing
have already discussed.
one thing, just you have the first, it was 1.5 centimeter above urethra. What does it mean? Means it has gone beyond the urethra, or
No,
it was just sort of urethra.
Below the urethra, lower part of the urethra, ma'am, sir.
So lower urethra, it has gone up to 1.5 centimeter above the urethra orifice. Is it so? So have you resected the urethra margin?
The first time her urethral margin was resected, 2 centimeter urethra was resected. First time.
Okay.
But now the lesion, they involved the whole urethra, the labia, mons, and it was fixed to the underlying structure and also bilateral inguinal lymphadenopathy.
Because first time when the urethra is involved, it was not stage 1.
Yeah.
It was a stage 3 disease now.
Stage 3, yeah.
So perhaps we have some missing link is there. That's why we are facing this problem now, most probably.
But she now everyone on of your opinion is to treat with the patient either the chemoradiation, upfront chemoradiation followed by surgery, or otherwise the chemoradiation. But
Yeah.
this patient, she was referred to the radiation oncologist and she was treated only with the radiotherapy.
Yeah.
Next, Shushmita, show the next slide. Yeah, she
She
received
received 28 fraction of EPRT, and it ended on 3rd August 2021. She received only radiation therapy, no chemotherapy. So is it justified?
One second. Can I ask you a question here?
Yeah.
Yeah.
You're talking about radiotherapy, but you're not talking about the radiotherapy fields. Whether you are including only the mons, pubis, and vulva, or also you are included the bilateral groin. Why I'm asking you this question is that she's already undergone inguinal lymph node dissection, and now again she has got inguinal lymph node recurrence. So if you're going to give radiotherapy to both the groin and the vulva, then morbidity is going to be extremely high.
Yeah.
So I want to know from you, what are the radiotherapy fields in this particular case?
So she did not undergo inguinal lymphadenectomy. She only
Yeah.
underwent wide local excision.
Yeah.
Oh, she has not had inguinal node dissection?
No,
No
sir.
surgery, no
It was
excision.
incomplete, sir.
No, first surgery was only wide local excision.
Yeah, it was an
No.
incomplete surgery.
No inguinal lymph node not done. No.
No. First surgery, it was radical vulvectomy with bilateral inguinal lymph node dissection.
Yes.
But this time, this growth was fixed with underlying structure and also bilateral inguinal lymph node lymphadenopathy, and then she was referred to the radiation oncologist and she treated with patients only with the radiation involving the covering the both inguinal region.
Dr. Shana, there was no report of pathology regarding the inguinal lymph nodes.
Yes, because they missed that. When I have shown that she missed that inguinal lymph node report, and when she received the slides from here and it was reviewed. There's when we will have to take the slides, and the patients has to pay for it because for fixation everything. So sometimes when we request the patients to take all the slides stock, in that cases sometimes they take the original tissue, not the whole the things, and they consult with us. They only when they visited the neighboring country, they asked for reviewing all the slides and block. They took only the tissue, original tissue, the vulvar tissue, that is the block, not the inguinal lymph node. So it was missing there.
Okay.
But this time she received only radiation when after recurrence, and chemotherapy is not given along with the radiation only, and the covering the whole both inguinal lymph node area. And what she should go for now? Does she go for again chemotherapy, and what she should do?
See, it is difficult to say because the treating physician would have seen her, and there could be reasons why she was not given concurrent chemotherapy. Maybe she had some comorbidities. Maybe age was not on her side. The other thing, maybe it would also have depended on the technique that was used. If you're using conventional techniques and with the pelvic lymph nodes being involved, Dr. Bafna put a very valid question that what were the radiation portals? So in that case, the radiation portals would have been very big. Generally, patients tolerate concurrent chemoradiation with IMRT very well, where we can do dose escalation. So probably a dose that has been given here is probably 50.4 grain 28 fractions to a huge volume of the vulva, inguinal, and pelvic lymph nodes.
Yeah.
So maybe there is a reason that is why concurrent chemotherapy was not given, because it would have enhanced the toxicity. So, right. I mean, saying that it's absolutely wrong that concurrent chemotherapy has not been given is probably not justified if we, discuss this on this forum, because we need to ask the physician what was the contraindication for the same. Yeah. But if you are treating these patients, yes, you should go in for IMRT with concurrent chemoradiation because the tolerance is very well. There are very few short treatment breaks when you use IMRT.
So now what will we do with this patient? Will you again request the treating physician for chemotherapy and adjuvant, or only she will go for follow-up? What will do with this patient now?
No, she has had a complete response.
Yes, it
Yeah,
looks-
just she
it seems so.
completed 2 months ago, her radiation completed. And now she is okay. After 2 months first follow-up, the local area, there is no disease in the local area.
Has a biopsy been done? Has any imaging been done? to
Yes,
confirm? Do we have a pathological complete response? Because the dose of radiation is inadequate.
um, just first time after completion of her radiation, she visited to us and we have found that local area there is disease free and there is, and we have asked the treating physician, probably somehow she missed due to the patient load. And now our question is, what will be her next follow-up or treatment option in that case?
I think she should have an imaging to confirm the response. The imaging should be a CT chest, abdomen, pelvis, if not a PET CT. Because
Yeah.
I think somewhere in one of the reports, it was also mentioned that there was a lesion, a single lesion in one of the lobes, and I couldn't get which lobe. Did they mean there was a lesion in the lung? So I wasn't clear about that. That was also mentioned in one of the slides.
No, it is, but it was a cyst, just a cystic lesion in the liver or something. No lesion in the lung.
Okay, so we also need to know the status of the pelvic lymph nodes,
Yeah.
whether they have resolved or not, and also the inguinal lymph nodes. And then we need to go and decide whether she needs any treatment or not. In fact, the response assessment should have been done after completion of radiotherapy. The patient should have been referred to the gynae-oncosurgeon. And that is the time when an imaging should have been done. And if the disease was localized, she could have been considered either for excision or the dose escalation should have been done to take the doses up to 66 gray, if we were planning a radical chemoradiation. Or if you feel she has had a complete response, then it has to be a pathological complete response. In that case, we take a biopsy from a region, and if it's a pathological complete response, then we keep the patients on follow-up.
Dr. Bhavana, they said that vulva is looking healthy.
Yeah.
Vagina is looking healthy. That means obviously she has got pathological complete response. At least clinically, at least looks very healthy.
Yeah.
I'm very surprised that it's looking healthy.
Yeah.
Patient has got recurrence second time. She's got inguinal lymph nodes and she has responded so well to radiotherapy. Actually, I'm a bit surprised.
That is exactly what even I'm thinking, sir. I mean, that's a very subjective term when we say it's looking
Yeah.
healthy.
Yeah. It's subjective, yeah.
Yeah.
Firstly, with IMRT or this cobalt?
Sushmita,
Yes, ma'am, I can't understand.
Do we have the radiotherapy
is
details?
it IMRT or cobalt? Do you know?
No.
No, there's no details.
No.
Yes. Because with cobalt, the vagina and vulva should not look healthy after 2 months. There
No,
might be
because they
some
don't look healthy
sort of,
normally.
yeah,
That's why
yeah.
I'm a bit surprised.
Yes, most
Yes, I would have expected the
IMRT, yes, one can think of, yes, there is.
Yeah, I'm a bit surprised. They don't look healthy after radiotherapy. We will find some kind of edema.
Yes.
No, the specialist is undergone lymphadenectomy. So definitely there will be some lymphedema.
Yes.
So I'm
Especially-
surprised that everything is looking healthy.
So that is why, I mean, I think we need to reassess her properly, clinically,
Yeah.
and with imaging.
Okay. So should we go for our next case? We have another recurrent case, recurrent vulvar case. Sushmita, shall I share that? Sushmita,
Yes, ma'am, you have to share.
okay. Please, Sushmita.
No, not this one.
This one? This one, I don't know.
Ma'am, other one, not this one.
Why we cannot share it? because the two patients have the same name, Onita and Onima. This is Onima. Onima.
Yeah. No, no, not this one. Onita.
Yes, I was sharing the Onita. So why did you told me that it is not Onita? It's so funny. It's so funny. Onita or Onima? Which one?
Onita.
This one? I think this one. Yes.
I can
Please
see
go.
the slide. I can't see the slide.
You can't see, but this one that time I was sharing. Funny.
Yeah. Okay.
I was sharing this that time. Ready. Okay, go through.
She's a 60 years lady diagnosed as a case of vulvar carcinoma from March 2016. It was well differentiated squamous cell carcinoma. Next. Next, ma'am. She underwent only wide local excision without groin lymph node dissection on April 2016. On her histopathology report, the vulvar tissue was 5.3 into 4 into 2.5 centimeter with exophytic growth measuring 2.8 centimeter. Microscopically, it shows verrucous carcinoma showing papillomatosis and club-like extension, and tumor was present within 1 millimeter of deep section margin. Finally, histopathology report was well-differentiated squamous cell carcinoma arising in verrucous carcinoma. So my colleague has already discussed, in case of positive margin for invasive disease, option is either reexcision of, if negative margin for invasive disease, observation or adjuvant external beam radiation therapy based on other risk factors. If positive margin for invasive disease, adjuvant EBRT is advocated. If positive margin for invasive disease but unresectable without extensive approach, adjuvant EBRT is recommended. So what is the importance of groin node dissection in vulvar carcinoma?
No, I think in this case you are talking about verrucous carcinoma.
Yeah.
You have shown the NCCN guidelines for squamous cell cancer. Okay, these guidelines don't hold true for verrucous carcinoma.
Yeah.
Verrucous carcinoma are locally aggressive tumors.
Locally
Don't spread to the lymph nodes.
They don't require lymphadenectomy also.
Yeah, they don't require lymphadenectomy. They don't require radiotherapy. Only thing is, what is required is good surgery.
Yeah.
Good margins.
But here she had the only 1 millimeter the margin.
Okay, she had 1 millimeter margin. So what happened afterwards?
Just go back to slide. Go back.
This was over 2016.
Next slide. This is one different carcinoma arising in verrucous carcinoma.
Yeah.
It is difficult to digest now.
Yeah. Yes, sir.
John?
Yes, there is a dilemma. We'll go, sir.
No, so actually what happens is that verrucous carcinoma is a variant of squamous cell cancer.
Yes.
Okay, so I think
so
verrucous
it's a
carcinoma,
verrucous
variant of
carcinoma.
squamous cell cancer is locally aggressive. Does not spread to the lymph nodes.
Yes, sir. Dr. Bhavna, what is your opinion?
Yeah, so I completely agree with Giri
Yes,
sir
sir.
and Dr. Bhavna. Verrucous carcinomas are well differentiated, very well differentiated forms of squamous cell carcinomas, and they are not as responsive to radiation. So that is why surgery is always a treatment of choice.
Yes.
And the preferable mode of treatment in this patient would any day would have been re-excision to get a negative margin,
Yes.
a free margin.
Yes. Yes.
So lymph node management philosophy in vulvar carcinoma, it is the single most important prognostic factor. If tumor size is up to 2 centimeter with less than 1 millimeter stromal invasion, lymph node dissection can be omitted. Ipsilateral lymph node dissection is done in case of tumor size more than 2 centimeter with stromal invasion more than 1 millimeter. Bilateral groin node dissection is recommended in midline lesion or large lateral lesion, or if ipsilateral positive nodes. She received adjuvant chemoradiotherapy with cisplatin weekly for 6 cycles and EBRT 30 fraction up to September 2016.
Just I cannot just because it is a verrucous carcinoma, and the lymphadenectomy is not required. You have not done nicely. It's good that you have not done anything. Then only 1 centimeter. We are only worried about that. There is a margin is 1 millimeter.
Positive.
1 millimeter margin is there.
Yes.
Very close margin.
Yes.
But as per the guideline of the British Gynecological Society guideline, the
Yes.
margin don't worry about margin, because the recurrence will be at margin only. So you can remove that. Either you can remove now or you can remove when there is recurrences. So what is the idea of giving this cisplatin, all these things, and I don't know why it is given. In one hand, lymphadenectomy is not required. It's nice, not done. But why you have given this concurrent chemoradiation?
So you all have discussed these things. Radical local excision is the standard treatment in case of vulvar squamous cell carcinoma in verrucous variety. And radiotherapy is contraindicated because it may induce anaplastic transformation with subsequent regional and distant metastasis. In August 2017, she came with the complaint of soreness and ulcerated lesion in the vulva. On local examination, an ulcerated growth 2 into 2 centimeter at the lower end of the previous incision line of the right vulva, extending medially, not involving urethra and free from underlying bones. And there was no groin node palpable. She underwent radical wide local excision on 26 August 2017. Histopathology report was squamous cell carcinoma grade 1. Peripheral margin was 2 mm. Deep resection margin was 3 mm and maximum depth of invasion 3 mm. Tumor board decision was radiation therapy, but she denied and traveled to foreign country.
Now, why was the decision taken for radiotherapy? She's already received radiotherapy, isn't it?
Yes.
Yeah.
Now, why second radiotherapy?
The second time she was
After her second
recurrence. 2017, again recurrence. And
No, but
after recurrence, she has undergone surgery. Sir, after recurrence, she has again undergone wide local radical excision, and radical excision peripheral margin is only 2 millimeter, deep resection margin 3 millimeter, and the maximum depth of invasion 3 millimeter, LBSI not identified, perineal invasion not identified. For that reason, probably she was tumor board decision was.
No.
Yeah,
My reasoning is re-irradiation is very difficult. To give radiotherapy for the second time.
Bhavna madam, please.
Yes, I completely agree with Dr. Bhavna. Re-radiation in 1 year in a region like vulva is extremely difficult.
Yeah.
It is really going to add on to the morbidity. The only thing that could have been considered, what was the dose that was given initially?
Yeah, 60 probably.
60. So a lot of dose has been given already. Otherwise, if you have a recurrent vulvar verrucous carcinoma like that with a margin close and it cannot be re-excised, then another option can be local brachytherapy in these patients.
Yeah. Yes, local brachytherapy. Probably
That's safer.
she was advised for local brachytherapy, but she denied and she had traveled to neighboring country.
Now, yes, but once 60
Yeah.
gram of dose has been delivered, it is going to be very difficult to even
Yeah.
give brachytherapy because
Yeah.
the structures of urethra and these are very sensitive areas, and the tolerance, they are not going to be able to achieve curative doses to these areas because they've already received enough dose. And the time between the recurrence is too small to allow us to deliver large doses of radiation.
Here her slide was reviewed and it revealed well-differentiated squamous cell carcinoma, and maximum depth of invasion was 3 millimeter and tumor at a distance of 3 millimeter from the deep resection margin. So there was no report of a verrucous variety of squamous cell carcinoma. Next. Her ultrasound of pelvis was unremarkable. MRI pelvis revealed irregular scarring and distortion of anatomy at the vulvar region, a few 6 mm right inguinal nodes, and PET scan revealed mild FDG uptake in soft tissue thickening involving the vulva. So recurrence could not be ruled out. So on the 2018 January, she underwent radical vulvectomy with primary closure in the neighboring country, and tissue was removed from previous scar with a 1 centimeter margin. Bilateral groin nodes was not enlarged, hence not addressed. Histopathology report was no residual disease. 6 months after her radical vulvectomy, wall smear revealed no epithelial abnormality. So what is the role of vulvar smear in follow-up? Bhavna ma'am.
Oh, again, I'm surprised, very much surprised. She has had radiotherapy twice, isn't it?
Yeah. Yeah.
And she had 2 surgeries. Second time she had a radical
Not
vulvectomy.
radiotherapy twice. Radiotherapy single time.
Single time.
And
Radiotherapy
entire vulva was removed.
Fourth time surgery, sir. Fourth time surgery.
Okay, after radiotherapy.
No. Before radiotherapy, it is 3 times. At first, probably local excision, then wide local excision, then radical excision, then radical vulvectomy. After radiation, radical vulvectomy.
Okay.
So our question is there any role of the vulvar smear in follow-up for vulvar carcinoma, Dr. Bhavna? Dr. Bhavna?
No.
Is there any role?
No, there is no role of vulvar smear on follow-up.
Yeah, okay.
No, it's going to be very unreliable after radiotherapy. Very, very unreliable. Should not do it.
Yeah.
So 7 months after her radical vulvectomy, contrast CT scan of abdomen and pelvis revealed heterogeneously enhancing areas of 2.8 into 3.3 centimeter with ulcerated surface in the left labia majora, but no inguinofemoral lymphadenopathy or pelvic lymphadenopathy. She was then advised for frequent follow-up for monthly, but she was lost. On June 2021, she came with discharge, itching, and pain in the vulvar area. On local examination, there was a 2 centimeter right labial growth close to urethra involving lower 1/3 of the vagina, and there was another growth in the left labia around 1 centimeter.
It is 3 years. 3 years lost of follow-up after 3 years. Yeah.
PET scan was done and it revealed 3.4 into 2.8 into 3 centimeter mass at anterior vaginal wall with bilateral inguinal lymph node metastasis.
That is this June 2021. During the last 3 years, she was lost of follow-up, and June 2021, she was attended to the gynae oncologist with this type of fissures, and she advised her for the PET scan. And the PET scan report was 3.4, and this is the report.
Now, what will be her treatment?
Dr. Bhavana, please.
In all the cases, the inguinal node was never addressed. Is it addressed at all? All the surgeries?
Fourth time surgery. That is after radiation. They told that There is no, as because there is no inguinal lymphadenopathy, so did only the radical valvectomy.
When there is vulvar lesions, when there is recurrent vulvar lesions, the IFLND should have been done. Okay. Now there is again recurrence is there, and there is a inguinal node is there. Perhaps you can do again the surgery with a bilateral inguinal nephrectomy. This is my opinion, but it is a very hopeless case now.
Dr. Bhavna?
For surgery.
No,
It looks so.
it is lacerated. It is lacerated area. There is a growth in
just go back. Just go back.
Yeah.
Go back. Slide.
Yeah.
Here. Yeah. This region, the region can be removed. What I feel. Because
no, Giri, this region is involving the vagina also.
Yeah, vagina also. Yes, sir.
Lower part of lower vagina, no, lower one third.
Lower vagina. And there was also the discharge and foul spinning discharge and everything. There is the growth on both labial region, also the lower vagina.
And it is post-RT. So I don't think it's
radiation and fourth time surgery. Yeah. After fourth time surgery.
Yeah, so I don't think it's suitable for surgery right now.
Yes.
She's basically for palliation, I think.
Palliation.
Yeah. So palliative chemo or palliative radiation? What is your opinion here now?
Chemotherapy.
To either, actually.
Yeah.
If there are local symptoms, local radiation, small doses can be given to alleviate the symptoms. But chemotherapy also has, I mean, with verrucous carcinomas, even chemotherapy have the same problem. They are generally not very responsive.
No. At the last time slide review, there is no verrucous carcinoma. It was a squamous cell carcinoma.
Squamous, no, yeah, but see, the more well differentiated it is, the poorer the response to chemotherapy is going to be there.
Yeah.
One can try chemotherapy, but chemotherapy generally is not a very good modality when it is a recurrence, especially after radiation.
Yeah.
That is.
Yes, if you look at the lesion, I don't think she'll respond to chemotherapy.
Yes, sir.
She'll not respond.
No, she'll not respond. So whatever we are attempting is basically palliation and best supportive care. So we will do radiation if there are local symptoms to alleviate some, I mean, basically for the ulceration or if there is hemorrhage, and to the inguinal area if there are impending ulceration. The lymph nodes, I think, are small right now, so that could be done.
What they can do is now you have to go for clinical trials.
Yes,
patient can afford. I don't know how many can afford.
Third option is to go in for target.
I have a question to Dr. Bhavna, please. And what is the time gap between the re-irradiation of this type of cases in vulvar carcinoma or in carcinoma cervix, and what is the cause of that?
The lot depends on the factors that determine how we can re-irradiate is basically the time between the last radiation. So the longer the duration, the better it is. So a minimum of 2 years that is what they say should be a gap, but longer the better. So once.
Why this 2 years? Why this 2 years?
You have to give chances to the normal tissue to recover, and there is only a percentage of dose that can be delivered in re-irradiation. You cannot generally deliver the entire dose.
Yeah.
So approximately, if the patient is recurring approximately after about 5 years, that is a time when we can almost give near radical doses of radiation. Okay. It will also depend on the volume that has been treated initially. Yeah. So if the volume has been very large, then it becomes all the more difficult to irradiate to higher doses. Suppose this patient would have been treated with brachytherapy. If his volume has been treated has been small, then it is easier to irradiate. Okay, because the normal tissue, surrounding normal tissue would have been less exposed to radiation. Then third thing that will determine the role of re-radiation will be the kind of normal tissues that are lying close by and what is the dose that they have received. Are they very critical structures? Like in these kind of patients, the critical structures around would be the rectum, the urethra,
the
bladder. So that.
Hi. There is another option here, which is a pelvic examination with putting in flaps. I actually just recently had a case just like this. the issue of the inguinal nodes is for sure problematic. And I agree with all your discussion. It's sort of kind of sad. She's had this very long course. I also think about her suffering. She's going to obstruct her bladder at some point soon, looking at the at that tumor. I agree also that I don't think radiation really plays a role anymore. She's being radiated. All you're going to do is cause vault necrosis for her and fistulization. And I don't know that you're going to gain much control here. So again, I realize this is probably, but another consideration in a local regional recurrence where there's no sign of distant travel would be an anterior infralevator pelvic exenteration with a complete inguinal node dissection. And clearly, if she's got progressive disease, periortics, that kind of thing, you'd probably want to go in first and check that she doesn't have any spread. But if she doesn't, and all she's got is those inguinal nodes, that is another option for you. Plastic surgeon come in and do a myocutaneous transpositional flap, either from the thigh or from the abdominal rectus muscle. So that is another choice for her. It's very aggressive, does require a lot of post-op care. It will leave her with a urostomy. If you think that's not something feasible in your planning for palliation for her, you need to think about how to manage her bladder outlet obstruction, which is where she's heading. Do you think about a suprapubic tube? Do you think about nephrostomy tubes? Or do you think that you're just going to not manage that and she'll die a renal death, right? But if she has local regional disease, radical energy surgery is another option.
But it is not feasible to do surgery in that time because there is the continuous discharge, foul smelling discharge, and the whole the vulvar area and also the lower third or lower half of the vagina all were involved, and the patients, in that case, it was not feasible. The surgery was feasible during that time. So we planned for these patients for the palliative chemotherapy. The PET-CT was done, and PET-CT, there is the only there is this area, the anterovaginal wall with bilateral inguinal lymph node metastasis, and we have this. She received the palliative chemotherapy, a 3-cycle, 3-weekly, up to August 2021. And MRI, after completion of the palliative chemotherapy, there was a 2.5 into 2 centimeter growth at the lower end of the vagina, again with the bilateral inguinal lymph node. There is not too much response of this chemotherapy. And then again, the tumor board decision was re-irradiation with chemotherapy up to 6/11/2021. That is, she was treated with the capecitabine 500 milligram 2 + 0 + 2 for the whole the irradiation time, and also EBRT 45K, and with concurrent chemotherapy with mitomycin on day 1 and day 28. And after the 6 weeks of our follow-up, the completion of our radiation, this is the vulvar area. This is apparently healthy looking and no grand lymph node. This is the area. This, yeah. Are you happy with this? Bhavna? Dr. Bhavna?
Yes, I think this is a very good response and we should just keep our fingers crossed.
Yeah.
But now only the patients are complaint is, that is, yesterday the patient came on to follow up and her complaint is only the difficulty in mixation and the frequency of mixation.
Bhavna, if it was you, would you have used concurrent for re-radiation?
Sorry?
In re-radiation of this type of case,
Yes.
are you using concurrent or only radiation?
Dr. Kamal, we can use concurrent chemotherapy also because, I mean, I think that is going to add to the therapeutic effect. So if the patient is fit and young, definitely concurrent chemotherapy can be added.
Just for academic discussion, I mean,
Definitely it can be added.
this 50 gray, I mean, this 25 fraction, because it is a re-radiation. I mean, if it was at your center, what would be your take for the radiation? What would be your fractionation and How do you have managed? Because now we are happy with the response, but we don't know what is going to happen in long term.
In the future,
She-
yeah.
There is a very high chance of her recurring, but as long
Yeah.
as the response is there, it's good enough. Definitely, if she's well and fit, concurrent chemotherapy can be added. That generally
patient
does
is-
not
she's
add too much
happy.
to the toxicity.
She is happy as because she has no symptom continuously. The last 4-6 months she has discharged and she has to use the separate the pad and everything. Now she is totally okay. Only complaint is the difficulty in mixation and the frequency. Otherwise she is happy.
It's good.
Good.
So far, so good. As you said, keep the finger crossed.
Yeah.
Yeah. And for this time, she should come for regular checkup. Only
Yes.
earliest lesions will taken care of. One
Yes,
can do
sir.
surgery at that point.
Yes.
If the earliest small lesion will come out as a recurrence, one can do a wide excision, something like that, with a flap, something like that, we can do it. Because yes, she should come for regular checkup. Just
Next
tell
time
her.
we are ready for surgery again, sir. 5th time.
Yes,
It's
can
going to
done,
be
no
a
problem.
very high chance of wound essence because
Wound
she
essence, yes.
radiated
No, no.
twice.
We can take the help of plastic
It would be
surgeons. We can
very-
do
yes,
yeah.
graft, flap can be done.
Graft,
So,
yes, sir.
so we
Yes.
can do that. Yes, can be done. Just intimate us. What is there?
We can have another board, sir. Another two.
Yes, it's really case is very interesting case.
Yes,
because,
very interesting.
uh,
We had almost given up hope in the end.
okay.
So, Shahana, any more case or it's over?
No, it's over. It's over. Thank you. Thank you very much. Thank you,
Thank you.
Dr. Sushmita. Now I request the Dr. Mehdi to show the poll questions again, and then we'll go for the ending of the session. They show the poll questions now. Yeah, 30 seconds only is question. Next. Second question. Maximum the participants are giving the right answers now. There is a questions from Dr. Nita. In advanced cervical cancer, lymph nodes are removed. Yes, it is already discussed. And what is the right method to do valvoscopy? Giri sir, there is a question for you. What is the right method to do valvoscopy?
But we have given you this. There is a circle. I have shown that there are two. One is inner, outer, middle, and inner circles are there. Accordingly, we put that STK seed. It should be put 5%, not this in the 3%, and it could be kept for 3 minutes minimum. Accordingly, you just search for all the three circles, outer, middle, and inner circles, and accordingly plan out where there is lesions.
Yes.
So this is valvoscopy.
Yeah, these are the same things was discussed in her lecture, in his
Yeah.
lecture in last time. In vulvar carcinoma, in vulvar region, there is in that area. If we have to do for colposcopy, we must use the at least 5%, as because this area is very thick. And in cervix, we may keep their acetic acid 30 seconds to 1 minute, but here at least 2 to 3. Sir, it's minimum
minutes.
2 to 3
3
minutes.
minutes you can.
Yeah.
Yeah.
And there is another question. Would you have recommended surgery for the recurrence and disease appears extensive? Yes, it is already, I think it is already
Yes,
discussed.
can be done.
Yeah. What should be the minimum duration of allow for re-irradiation if required larger doses? Yes, it is already. Okay. Now it is the, I request our scientific secretary, Dr. F.M. Kamaluddin Bhai, to comment on today's the presentation, and then we will end the sessions after the hearing from the General Secretary, Dr. Sharif sir.
Shahana, I mean, the poll question shows that there was a good discussion.
Yeah.
So the better answer is shown after the discussion. So the target is achieved. So good discussion, and whatever message you want to disseminate, I think it has been disseminated. So it was a fantastic discussion, I will say, because we don't see many common cases, but once we see one case that kills our life. So we need to really be judicious. But the good news is that what I always feel that the vulva vagina in the cervical area is an area where if we can really give a good treatment, there is always chance of good outcome in a very advanced disease. That is the beauty of this area. So we need to use our judgment judiciously, because unplanned surgery or radiotherapy may ruin a good case and convert it to a bad case. So that is what we have learned from the discussion. And thanks to all the faculties, I mean, like Dr. Giri, Dr. Bhavna, AK, Bhavna, everybody have done a wonderful job in the discussion, and we learned a lot. And congratulations to your team who has presented the case. I can see the development of them now. They are really making a good presentation. And thanks to you for carrying this program forward on behalf of Oncology Club. We want to congratulate your team and all the faculties. Finally, the participants who made the program successful. Thank you very much.
Thank you, Dr. Kamal Bhai. And we have a message to all of you, all the participants. We are going to arrange a 3 days workshop on gynecological oncology, covering all the topics, that is cervix, vulva, and endometrium, ovary, gestation trophoblastic neoplasia, on next 7th to 9th January, and all are requested to participate in their sessions. And for registration, we will show and we will circulate the registration, all the everything. So all are requested to participate on the 3 days workshop, and all the eminent faculties, the renowned faculties who the last 1.5 years were with us. We have invited all of us, and everybody were they agreed to join the program. So all are requested for participating in that 3 days workshop. Now I request the Secretary General, Dr. A.M.M. Shariful Alam sir, to comment on today's presentations and also conclude the session. Sir, please.
Sir, কি আছে? মনে হয় না, দেখি নাই না।
Okay. Thank you very much. So thanks all the participants and also the faculties. Sir, thank you all.
Thanks to AK, I missed your name because we don't consider you as a foreign faculty anymore. That's why we missed your name.
Thank
you. So can we close the session?
Yeah, thank you.